being diagnosed with it?
There are some rare forms of motor neurone disease that affect infants and small children. Again, they're almost exclusively genetically determined, so there are some rare forms that occur in infants called Kugelberg-Vielander disease. I'll question, you've got to remember that, I'll question you afterwards. And there's some other forms of inherited neuronopathies, so motor neuronopathies. Amyotrophic lateral sclerosis, to my knowledge, I've not seen anyone younger than 19. I'm sure it does occur, but again, if you think... Pediatric neurology is very different to adult neurology, and the diseases that affect kids neurologically are very different to the diseases that affect adults. And if you accept that the incubation period, so the time from the time that the disease starts to the time that it becomes manifest, may be anywhere between 2 and 5 years. You know, it's hard to imagine that people would come on or develop their motor neurone disease clinically much earlier than 19. I think the keeper of the mic's determining where the questions are. So just wave. Yes?
The non-invasive ventilation, is that something like a CPAP which is used for sleep apnea?
Excellent, yes. So the question was, is non-invasive ventilation like the CPAP machine that's used for obstructive sleep apnea? Yes, it's very similar. So obstructive sleep apnea is a condition where your throat closes down when you go into REM sleep, and people snore and then get punched in the back until they turn over. And often what we see, so the thing in motor neurone disease is that the central drive to breathing is affected with nocturnal hypoventilation. So often patients who might have a history of snoring, when they get into trouble with their REM breathing, the snoring goes away. And often, you know, I say, do you snore? And the partner goes, yes. And then the partner says, yeah, but funnily, you know, the snoring has actually gotten a lot better of late. And that to me is a big red flag, because that tells me that the central drive to breathing is not as good. But yes, the machine is very, very similar. It's a little bit more expensive. So CPAP stands for continuous positive airway pressure. So it delivers this continuous cushion of air to keep your throat open, whereas bi-level ventilation gives you a burst of air when you take your breath in, so it actually senses when you breathe, and then it drops that pressure when you breathe out.
I have a friend who has sleep apnea, and she says that she feels so much better the next day after she's used the machine when she's sleeping.
Yeah, and that's again, so the comment was that it makes you feel better. And again, with non-invasive ventilation, with bi-level ventilation in motor neurone disease, often it improves people's energy the next day. They sleep a lot better. They can actually lie down flat. So again, one of the warning signs is orthopnea, where when you lie down flat on your back, if you wake up and it feels uncomfortable and you have to sleep on your side, so your diaphragm's not splintered. Yes, ma'am.
I have one here from the floor.
Yep.
Your things for acupuncture.
Acupuncture is a complete waste of time. Look, you know, if anything makes you feel better, then that's fine. You know, if standing on your head naked whistling Dixie works for you, then that's fine. But if you're asking my opinion, based on science, as to whether acupuncture helps with motor neurone disease, my answer to that is that there's not a shred of evidence that it does. In fact, there's evidence to suggest that acupuncture does nothing at all. But there are some patients that I look after and they love their acupuncture. It helps them with their pain, it helps them with their cramps. Symptomatically, it helps them. So if it helps you and you want to do it, do it. But if you ask me for my robust opinion as to whether I think you should do it, then I'll tell you. And if you don't like my opinion, that's okay too. You can say, because it is advice. It's not me telling you what to do. That comes back to my first comment, is that the patient is the expert. They know themselves 1,000-fold better than I do, as does their partner. And I'm, you know, sort of like the harp player.
You mentioned that the disease, as it progresses, spreads to adjoining areas.
Contiguous areas, yeah.
And I'm just wondering what your insights that gives into what's actually sort of going on behind the scenes.
Excellent question. And this is where a lot of the focus of the interplay between the glial cells, the supporting cells and the neurons, and also the why we get this transsynaptic spread of disease. So the BET cells talking to the motor neurons down in the spinal cord, up in the brain are the ones that are affected. And there's some very clever work that came out of Seattle where they actually looked pathologically at the regional spread. And it's to do, I think, with how cells are talking to each other. And those big, big clues have to give us big, big hints to get in and stop it.
Hi, Dominic.
G'day.
A couple of questions. First one is just in relation to if there's any sort of data being captured from patients or their families as to what may have occurred in the patient's life prior to the onset of motor neurone disease to try and identify patterns or life events, things like that.
So that's a great question. The question is, has there been systematic data collection looking at possible environmental triggers? Because everyone wants to know why. Why did I get this fucker? And there are a few little clues from epidemiologic studies, but again, the studies themselves always have to have a hypothesis to begin with, and then they go and collect the data. So there are quite a few huge databases. So in Olmsted County in Minnesota, into the Mayo Clinic, and there don't appear to be any major environmental factors when they've looked at just this one county in Minnesota. And there are some other very large studies that have followed physicians and other populations. And again, there don't appear to be that many clues. However, you've got such a low frequency disease that those clues may well be missed. We do observe clusters in our work because of our where we sit in Sydney. Down in Griffith, there are 14 people with motor neurone disease. It's a town of 40,000 people. Doesn't add up. Now, is it just a statistical cluster, or is there something there? And there are, again, various theories as to that. So one theory is blue-green algae. So again, in southern France, there's a cluster around a specific lake, and there's a little cluster down in New Zealand. And there's a chap over at UTS, and his name escapes me just for the second because my Alzheimer's disease is catching up. Brad, do you remember his name?
Ken Rogers.
Ken Rogers, who's doing some really, really clever work with how the blue-green algae may substitute into normal protein expression and then accumulate in these long surviving cells.
But no, of course, like trauma, whether it be physical or mental.
There may be some triggering of peripheral nerve trauma. We have seen quite a few patients who've had trauma and surgical repair of peripheral nerves who've developed eventually motor neurone disease in that arm or leg. And again, that goes to the host response to the injury, but then having triggered that injury, what are the processes in the nervous system that make it get worse? It's a little bit more common in people who play professional sport for a living, so Serie A footballers and gridiron players in the US. It's a little bit more common historically in people who work with electricity for a living. And in our clinic, we have had many, many nurses with motor neurone disease. It's a little bit more common in neurologists than other physicians. Sonia.
Can I ask you, is there any research in melatonin?
Research in melatonin is the question from Sonia. In motor neuron disease, I'm not aware of any research in melatonin. Melatonin is a hormone that's released from your pineal gland, and it's very critical in your diurnal cycle. So it kicks things off at 3 a.m. and enables you to get to sleep. And in some diseases, like in Parkinson's disease, there's quite a marked suppression of the diurnal burst of melatonin, and we often use melatonin in Parkinson's disease to help people stay asleep, but not to my knowledge in motor neurone disease. I'll look it up for you. Custodio.
Tom, you were talking about, you're talking about nocturnal. What about, if you have a nap in the afternoon, does that occur as well, the snoring?
So hypoventilation, yeah. Anytime you head into REM sleep, so whether that's asleep when I'm talking to you, or any time, if you head into, it's the REM sleep cycle that's where breathing tends to get affected. So yeah, if you're having a nap in the afternoon and you're using non-invasive ventilation and you're on bi-level ventilation, then whack it on in the afternoon. You'll sleep better.
LED light therapy, has there been any research in that helping?
I'm not aware of any. Again, I have to take that on notice. I don't really quite understand biologically, so just running it through my brain, I couldn't understand how LED therapy is going to necessarily slow the progression of motor neurone disease. But again, do you know of any?
No, I've just someone thought that there'd been studies done on LED light therapy beds and.
I often when I answer questions like this, we can go and find stuff, and you'll find stuff on the internet. What I think more useful is to apply your own rule of 4. So I sort of call it Rowe's rule of 4. So the first thing is, what's the biological premise of the therapy or intervention? Does it actually make sense? And it doesn't need to be a proof. It just, like for example, there's oxidative stress in motor neurone disease, and if I take antioxidants like vitamin E, that might help. Okay? So what's the premise behind it? How exactly is the therapy going to help you? Is it a symptomatic therapy? Does it change the rate of the disease? So the person who's telling you that you should do this therapy should actually tell you what it's going to do for you. Thirdly, how might that therapy hurt you? And there are several different forms of hurt. There's psychological hurt. There's physical hurt from unintended reactions or intended reactions. And there's financial hurt. So there are some therapies, in fact, down in southwestern Sydney, there's a charlatan, I'll say that in a public forum, there's a charlatan who advocates that he can take stem cells out of your tummy and inject it and change your motor neurone disease. And he'll charge you a lot of money to do that. And he has no premise for his statements on the website when you look at his website. You've come across that? Who's seen his website? And then lastly, you have to ask yourself, and we tend to think that people who are offering stuff are doing it because they're good guys and what have you. Well, you have to ask yourself, what have they got to gain? Because if they are getting direct financial gain, so the guy who's selling you the LED lights says that this is going to help your motor neurone disease, if you ask yourself, what's the biological premise? I don't know of any. How's it actually going to help you? How might it hurt you? And what's the person got to gain? And if you ask those 4 questions, that pretty much fails on every step. It doesn't mean that the question shouldn't be asked.
I have another one from a different one from the floor about checking on progression of your condition. Who do you go and see? Would it be the GP, the neurologist, or even the clinic, the organ? Who monitors your healthcare?
You have to be a squeaky gate. You have to be your own advocate, and you have to really be your own advocate. And for carers too, you've got to be your advocate. And you've got to get there and make noise. Most GPs will have one, maybe two patients with motor neurone disease in their whole career. And with the corporatisation of general practice, it's hard to get a GP's interest for more than 10 minutes. When I see a new patient, I have the luxury of sitting there for an hour and a half with them. GPs can't do that. They can't. And so, the clinic should be monitoring. That's the point of clinic. And clinic, again, so we look after 140 people, but we only have what's called 48 active clinic spots. So a lot of the other patients who come, who we look after, clinic isn't necessarily for them because it's quite a long afternoon. It's 3 hours and you get hammered. And so we're very mindful that people who aren't necessarily suited to that environment, so we run clinic at Macquarie on the 1st and 3rd Wednesdays in the afternoon of the month, and on the 2nd and 4th, Sandra and I run a much smaller clinic where we troubleshoot.
Brachial plexus inflammation and flail arm syndrome. Is there a definitive way of determining either one?
Excellent question. So brachial neuritis or Parsonage-Turner syndrome is a rare form of inflammation that occurs in the nerves under the collarbone. It often occurs in response to vaccination or minor trauma or operations after a pacemaker or dislocation of the shoulder. It is a very, very painful condition and is treated with, it's usually a monophasic illness, and it's treated with steroids and very rarely with intravenous immunoglobulin. Arm onset of motor neurone disease, sometimes it can be difficult to distinguish between the two, but basically time will sort it out. So, and the other thing in motor neurone disease, your sensory nerves shouldn't be affected. So Parsonage-Turner syndrome or brachial neuritis is after the sensory axon. So often you can see in the sensory nerves, you can see footprints. So it needs very careful neurophysiology done by someone who knows what they're doing. But yeah, it can be very difficult.
We had an MRI which had showed inflammation, but then we had a nerve biopsy which sort of ruled that out. It was just a bit confusing.
Yeah, nerve biopsy can be very confusing because there's a sampling error. Is the little bit that you take out the bit that's involved in the process? So if you're not looking in the right spot, you won't find it. Yes?
Oh, hi, yeah. This is regarding clinical trials.
Yes.
There are 6 going on at the moment. I don't know how much information you've got about any of them. So I've got the names of them here, which are Galenia is one. Can I read them?
Yes. So do you want me to deal with them each at a time, or?
Well, I just wondered, are they all the same? Or?
No, well, Galenia is the third one that I mentioned, fingolimod. So this is a trial that's being run by the ALS TDI, Therapy Development Initiative, which is a private not-for-profit at MIT in Boston. So I was over there 2 months ago having a good, vigorous discussion with Steve Perrin, the CEO. They've not yet done their safety data. They don't have any safety data on Galenia, on fingolimod.
The other one was to do with stem cells. It was the introduction of kenfolone or something like that.
The introduction of, sorry?
Kenfolone.
That's a person's name or a therapy?
No, that's the name of the molecule.
Okay. Again, I'll check that with you. I'll take it on notice. The issue of stem cell therapy in motor neurone disease is a very hot area, and there are some black box I should say that I think that stem cells as a replacement therapy to reconstitute the nervous system, I think is a generational task for us. There are some strategies where various different companies are looking at using stem cell therapies that have been modified to attenuate the biological process that occurs in motor neurone disease. So there's no, to my knowledge, convincing evidence that any form of stem cell therapy has reconstituted anyone's nervous system yet. I think there were a couple of other, were there any other drug trials that you wanted to talk about? You know, just to add on to that, I think that the drug trials, and the trials will come. The therapies that will come face quite a few hurdles, and they've got to leap this big chasm from a good idea in the lab over into being a drug that actually works today. So the average cost of completing a phase 3 trial, so to work out whether it works or not, is somewhere in the province of 80 to 100 million US. And there are very few companies that can cop that if it fails. And unfortunately in motor neurone disease since the early 90s, there's only been one partial success. So I believe that therapies will come, and that will come directly from our understanding the biology of the disease, working out how to switch genes off. And to illustrate that point, there's a form of leukemia called chronic granulocytic leukemia, which is caused by a chromosome switch called a 22/9 translocation. And that produces an on switch in a certain population of your blood cells and produces this form of leukemia. 12 years ago, if you had this disease, your mean survival was less than 3 years. Your only chance at survival was marrow transplantation, either matched unrelated donor or from one of your siblings or parents. It was the only chance. Drugs didn't work. And some researchers at Dana-Farber Institute in Boston worked out that the protein switch caused a thing called a kinase, which phosphorylates things within your cell, and this kinase was permanently switched on. So they went to a company called Novartis and worked with them because they had a whole host of molecules that they knew were active against kinases. And they found that they could turn this protein off, this gene manifestation into a protein. They could switch it off with this tablet. And then the lawyers got involved. And the accountants got involved. And Novartis said, well, there's only 3,000 people a year get this form of leukemia in the whole world. Why are we going to spend 80 to 100 million to work out whether this is worthwhile or not? So they almost fucked it up. The guys from Dana-Farber knew that their stuff worked. They knew it. So he resigned from Dana-Farber and moved out to Sun City, to Sun Institute in Phoenix, Arizona, and bought the rights to develop as long as Novartis could buy it back once he'd proved that it had worked. And they proved that it worked. It stops CGL dead. You still got to take a tablet every day, but your leukemia doesn't get worse. And we have a tablet today called Glyvec, which you take a tablet every day, and your leukemia is not cured, but it's controlled. And my second cousin has had a second child on Glyvec. So there's no doubt, I have no doubt, that therapies that will change this disease, that will slow it and stop it, will come. And they will come from good research. And it's going to be brute strength research with really clever young people asking questions that no one else has thought before. Hans Krebs, who's one of my heroes, was the father of modern biochemistry. And he quoted famously, he was 25 when he discovered the citric acid cycle, and no one believed him. No one would publish it because they said he had to have fabricated it because it looked too good. And he was rejected and rejected and rejected. And he said, you know, science moves forward because young scientists do experiments that old scientists knew wouldn't work. Isn't that true, Brad?